Hello and welcome to the RSNA Radiographics podcast. My name is Jennifer Weaver and I'm a musculoskeletal radiologist at the University of Texas, San Antonio. Our episode today is being recorded at the RSNA 2024 meeting in Chicago, Illinois. My guest for today's podcast is Jonathan Revels, a chest and body imager in the Department of Radiology at New York University. Today, we're going to discuss his radiographics article from 2022 entitled Upper Gastrointestinal Fluoroscopic Examination, a Traditional Art Enduring into the 21st Century. Dr. Revels, this is somewhat full circle for us, as I was one of your fluoroscopy faculty when you were a resident. That was a few years ago. Endoscopy and cross-sectional imaging have progressed significantly since then. Are fluoroscopy and barium still relevant in the 21st century?
Thank you so much for the warm introduction, Dr. Weaver, and for being such a wonderful attending, friend, and colleague throughout my rad life. This presentation was so fun to put together, and I owe a huge thanks to my amazing co-authors as well. Now to answer your question, GI fluoroscopy and barium studies are definitely still relevant in radiology practices. And throughout our podcast today, we will unpack the many reasons why that's true.
Okay. Well, what do you see as some of the benefits of fluoroscopy upper GI exams?
This is a great question, and one that I think is often buried in a more common question that we hear, which is, what is this offering that CT, MR, or endoscopy don't already provide us? And while the short answer is fluoroscopy allows us to simultaneously evaluate anatomy and physiology within a single non-invasive study that doesn't require sedation. We are able to assess things like lumen size to evaluate for strictures, mucosa to look for inflammatory changes and lesions, GI motility, and in cases of postoperative patients, we can look for complications like leaks and truly challenge the area of concern, meaning get that contrast to lay on the site and check for a leak. We also gain the benefit of patient interactions. Now, patients are the true custodians of their histories, and fluoroscopy brings them into the fold as a partner in the exam, allowing for us to potentially better evaluate the causes of their symptoms.
Well, we all know that we're getting busier and busier every day. How can we balance our workload with the time involved in teaching these examinations to our residents, as well as the time necessary with some of these complicated, complex studies?
I hear you, Dr. Weaver. And in order for our radiology community as a whole to be able to provide high-quality GI fluoro studies, we have to accept that there is a lot of upfront, meaning front-end work required. And this comes in the form of good resident education, laying that strong foundation on the basics of how to perform a complete upper GI exam from beginning to end that learners can default to when needed is what's key so that they understand the whys, the hows, and the whats for the study. Then, once that foundation is laid well, we begin understanding how we can truncate the exam to investigate for more specific indications, such as complications in post-op cases, as well as understand when fluoro might not be the best test to answer the clinical question. And all of that is just my long way of saying, I know every radiology department is getting busier and busier. But if we continue to invest our time in teaching GI fluoro on the front end, we will see that it does have downstream benefits for us all.
I agree. We reap what we sow. What are some of the different pathologies that can be diagnosed with upper GI studies?
Well, this is going to depend on the type of upper GI you're performing. So for a double contrast study, meaning we are giving gas crystals and liquid barium suspension, you can assess GI tract mucosa in addition to evaluating morphology and motility. Mucosal abnormalities include things like features of esophagitis and even mucosal lesions like polyps that could be due to a primary gastrointestinal process or sometimes even metastatic disease. Now, single contrast barium studies are done as part of the double contrast upper GI, as well as by themselves in cases where an institution might not do double contrast, or if double contrast is contraindicated, such as recent GI surgery or patients with bowel obstructions. In these studies, we get an understanding of morphology and motility, but they're not so great at providing mucosal details. So we can see where there might be a GI tract stricture and dysmotility on them. Then we have the water-soluble single contrast upper GI, which means we are using an iodinated contrast medium instead of barium. This is going to be primarily used in cases where there's a potential for contrast to extravasate from the bowel, such as a postoperative patient or a trauma patient where we're doing a leak or perforation check.
Okay, well, let's jump into the details of upper GI studies. What are some important things to know about your patient before you perform an upper GI study?
So it really comes down to gathering information that falls into two broad questions. Why are we doing the study, and what is the patient's status? So when you know the answers to these two questions, you can begin to figure out how you're going to do the procedure so that we can practice our overarching goals in medicine and radiology, which are first do no harm and as low as reasonably achievable, or ALARA. We want to make sure that the upper GI is performed safely for the patient, for our staff, and for ourselves, and this includes things like knowing if the patient is able to perform the maneuvers we need to attain the answers to the clinical question. This also includes knowing what the patient's level of mobility is, and in some cases, it can be extremely limited due to recent surgery or even overall mental status. In these limited patients, you'll want to consider multiple modifications to your upper GI beforehand, such as not being able to obtain upright images, or maybe going ahead and having the patient in the most ideal position possible to evaluate the area of concern from the very beginning. When you plan ahead, you'll have less surprises during the procedure. And lastly, it's important that we always remember that medicine is a team effort, and that requires a lot of communication. If you have concerns, say something and talk it out with the team before you have the patient there with you.
These studies can sometimes be so difficult to perform for one reason or another. Can you talk about some of the pitfalls that one might encounter?
Absolutely. So some pitfalls of double contrast studies include poor contrast coding and poor luminal distension. In these cases, you could try having the patient drink some more thick barium to better coat the esophagus or the stomach, or maybe you have them roll a couple more times to coat that stomach better as well. You could also try another dose of gas crystals to improve the luminal distension, but the caveat here is that this can cause patient discomfort, and if you over-distend the stomach, that's going to lead to poor coating as well.
That makes sense. We talked earlier about some of the pathologies that one can encounter during upper GI evaluations. How do we use these studies to evaluate the postoperative GI tract? What are we looking for in postoperative patients?
Well, again, this is really going to depend on what the order is trying to answer with the upper GI, as well as what surgery was performed and when. I think leak check is one of the most common indications for an upper GI in postoperative patients, which could be just a routine study to make sure there isn't presence of a leak, just as part of the postoperative algorithm. But sometimes it's being requested because a CT was performed due to the post-op patient having pain and there's concern for a leak. And the single contrast water-soluble upper GI is being done to see if the leak is present at that surgical site. And this will be seen as extravasation of that ingested contrast. Now, when I say extravasation, what I mean is the oral contrast is not staying in the bowel lumen like it should. And you're seeing it flow freely into the peritoneum, or maybe it's communicating with another bowel loop in the case of a fistula, or it's pooling outside the lumen because it's a contained leak. What I really want people to remember, though, is that when you're evaluating an operative patient or a post-op patient, you have to make sure that the contrast is 1, reaching the site of concern, and 2, challenge the anastomosis. Just because the contrast is at the location of the surgery does not mean you've adequately evaluated that surgical site. For instance, if the duodenum was patched anteriorly, but you only performed the upper GI in the supine position, you cannot guarantee that the contrast ever touched that anterior wall where the patch was placed. And since contrast will settle with gravity, it could just be layering dependently and not contacting the anterior wall at all. So you have to position the patient the best you can to get that contrast to contact that anterior wall and test the integrity of that surgical margin. So lastly, it's important to remember that delayed imaging in these post-op cases is really important. Sometimes you won't see the contrast extravasate during the fluoroscopic part of the examination, but then you get a post-procedure overhead radiograph and the contrast is clearly leaking at the area of concern. Other times, though, the patient gets a study like abdominal radiograph later in the day or the next day because they're still having pain, and you want to make sure that you're looking closely at the surgical drains because if there's contrast within them, that means there is a leak present that you just weren't able to see on the upper GI. You want to then contact the team and let them know of the leak being there.
So, when can we use these upper GI fluoroscopy studies in addition to cross-sectional imaging?
The upper GI can really help complement cross-sectional imaging, as in the case of follow-up to findings of a potential leak on CT like we just talked about. But also, upper GI exams are not perfect, and some diagnoses may be better seen with CT. In fact, there are actually studies that have shown that our sensitivity for detection of leaks following things like esophagectomies goes up whenever we perform both the fluoroscopic upper GI and a CT esophagram.
This has been a fun review of the fluoroscopic upper GI examination. Thanks for reviewing all of this with me today, Dr. Revels. This is a great radiographics fundamentals from you and your co-authors, and I encourage anyone who's performing these examinations or learning to perform these examinations to check out their detailed instructions and images in their article. Thanks for joining us.
Thanks so much.